20 years ago, health systems would buy physician practices. And the reason for that was that they wanted to own physician practices as feeders into their system. Today, health systems aren't buying primary care offices anymore. It's the insurance plans who are buying the physician practices. And now their role is not anymore to be a feeder, but more to be I wouldn't say blocker. Physicians still refer patients to specialists and hospitals, but less so and more judicially so. And I think that has become the new role. So it's very interesting. You see that just in the market, you see the effect of that change, that now primary care physicians typically are the organizations that have the financial incentive to keep people away, to avoid as much as possible acute care.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Greg Malkery, and joining me is my co-host Keith Washington. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Joining us today is our guest speaker, Dr. Harm Scherpbier, Adjunct Professor for Population Health at Thomas Jefferson University. Harm, welcome to our webinar. Would you like to introduce yourself?
Yeah, thank you, Greg and Keith. Good being here. My name is Harm Scherpbier. I teach health informatics and health data science at Thomas Jefferson University College of Population Health. I'm also the Chief Medical Information Officer at Health Share Exchange, that is the Philadelphia Regional Health Information Exchange Organization.
Great, thanks, Harm. Keith, do you have any opening remarks for today?
Yeah, thanks, Greg. So Beyond the Blueprint is really all about managing complexity, to get feedback from thought leaders about how they focus on their mission, what successes they're having in dealing with complexity. I'm really looking forward to the topic today, particularly when it comes to population health, because it sounds a lot easier than it is. It's very complicated. I'm really looking forward to the speaker and hearing from Harm today.
Thank you, Keith. Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible: Storage Systems and Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. So with that, why don't we get started? And let's start off by talking about system design. Harm, with your deep involvement in population health, what's your vision for integrating digital tools within health system design to enhance outcomes?
Yeah, that's a great question. And I'd like to start by just quoting Dan Martish. He's the Chief Health Information Officer at Trinity Health, and we did a panel at the 2024 HIMSS, and his line was so memorable. He said, "Form follows finance." Typically in design, that form follows function, but in healthcare, form follows finance. So that is design. It means that whatever finance mechanism, whatever reimbursement mechanism we have in healthcare, that will then drive and dictate the design of how care is delivered. So I think when we talk about population health, form follows finance is a great ground rule, because it starts with reimbursement mechanisms and payment mechanisms that then drive how the team and the provider and the patient behave and work inside a population health system. So I think that's the starting point of the design.
Harm, how does finance influence the design of healthcare systems under value-based care?
It shifts the financial incentives from the health plan, the payer, to the provider. It, in many ways, combines these payer functions and provider functions into one single organization. We jokingly call Pay-Viders, a blend of provider and payer. And that means that party, this healthcare practice that takes on financial risk, is now not just responsible for the care delivery, but also for managing utilization and managing financial risk. And that requires design. So under what I would call value-based care, which is another term for population health, value-based care, we're redesigning how physician practices work, and we're rethinking the players in the team. For example, it's not just a physician and an assistant and an office staff. We're now adding social work, care coordination, an assistant, behavioral health, and community workers. That's forum following finance, to expand the team members in a typical practice to address many other needs for the patient in order to fulfill that role. We're also redesigning tools. For example, in the traditional health record, you would just record in the traditional the patient-provider relationship. But now, to manage a population of patients for which I'm at risk for my health plan, I need population health management tool, population health management systems, and they're much more focused on managing and tracking the care for all the patients under the care in my practice. And then last topic is engagement. We'll talk more about that later. Patient engagement, provider engagement, also using EMR tools and other design settings. So we'll talk about that in a minute.
Yeah, so Harm, I really appreciate, that perspective about the forum follows finance, particularly, as we're going through a lot of change, reform, adapting, and adoption of different models. And it's all part of that complexity. And it really is, it's so important to think about that principle, because really without the resources, then you really need to be existing in an operational reality that's consistent with your financial capacity. So it's a little bit complicated, I think, within the health systems, where these roles before were, say, more siloed or segmented. And now, as you described, you're getting a shift, from payer to provider, which in our world, we like, in Beyond the Blueprint, as we talk to different thought leaders, we think about it as integrate and co-create, where we have both sides kind of doing some give and take and thinking about how we can create aligned incentives, how we can manage opportunity cost, how we can make trade-offs, because at the end of the day, we have a lot of trade-offs to make. So I guess in what you're seeing as this, let's say, transition is occurring, I guess, are we moving faster, slower? I guess, how do you think about the pace of this managing complexity in the finance part?
It's a slow change. It's a gradual change. It's a change that takes place over years, but it's a noticeable change, and I think it affects every participant in the health system. So it's not overnight switching from all fee-for-service medicine into all value-based care service. As a matter of fact, if you look at the number of dollars that are currently under value-based care, it's between 8 and 10%. It's a small amount, but that 8 and 10% is already having a huge impact on how physicians are incentivized and how they behave. So it's a very gradual change. It's not 0 to 1 in one day. It's taken, and it will take much longer, but it's enough to have an impact on how organizations reform themselves into value-based care today.
Thank you.
Great, thanks, Harm. Harm, let's talk about operational barriers. As we shift toward value-based care and we integrate population health models, what are the operational challenges you face in implementing digital strategies to support patient engagement?
Yeah, that's a good point. Well, there are many operational barriers, but let's start with one of the obvious ones. We call this the two canoes problem. I don't know who coined the term, but certainly Dr. David Nash at the Jefferson College of Population Health, he uses it. And it means one foot is in the fee-for-service canoe and the other foot is in the value-based care canoe. In other words, I have these dual incentives going on at the same time. And how should I, as a practice or as a hospital or as a physician, how should I work with these 1 foot in each canoe? You're dealing with two different business models, each with different incentives and each with different payment systems.
What if you could tell me a little bit more?
Yeah, it's, I said it's two. It's actually more than two. Because fee-for-service is one thing, but value-based care is multiple things. There are all kinds of different value-based care plans, from moderate to high. Sometimes it's just a set of value-based incentives or quality-based incentives. Sometimes it's all the way per member per month payment, capitation, and all these plans exist together at the same time. So as a practice, I may have a panel of patients, some of whom are under a traditional fee-for-service plan, some of whom are under a plan that gives me a number of quality-based incentives, and for some of those, I'm fully at risk using capitation. And that's why this transition is so hard. Some practices solve this by going all in on a single model. For example, ChenMed or Oak Street Health, all their patients, or at least the majority of their patients, are on a Medicare Advantage plan using the same incentives. But others manage it by using IT tools to manage how to best take care of each group of patients. Some practices stick to working the same way for all patients, and I get that. I totally understand that. They feel, hey, I take care of all my patients in the same way. But my concern there is that's not how incentives work, right? I think there has to be a way for incentives have providers consider incentives on how do I manage patients with chronic illness, or how do I keep patients out of the hospital, or how I proactively deal with patients with social and community situations. That requires a collaborative strategies between the providers, between the payers, and also between technology partners to streamline that adoption. So I think that adds a lot to the complexity, but I think it's important that we recognize that, and that's part of the transition.
Great.
Well, yeah, and I like at least that thought process in terms of managing complexity and getting different players in the marketplace kind of focusing on a particular area, because a lot of times, like in other parts, other industries, that's how it works. Like you'll have like established ways you've been doing it for a long time. You have large organizations that are not as flexible, but if you can let like some organizations really focus on refining a certain business model or a certain standard, I mean, that's part of how you could manage the complexity is let some of that sort out. And that's really encouraging to hear that you'll have people doing that, because then that'll push the bigger organizations to adapt to try to compete. Because really at the end of the day, I think that's where we're going to find the transition continue to make steady progress, is when you have, in the marketplace, you have different people coming at it from different directions, trying different things. And eventually it kind of gets sorted out through the financial, what's going to be winning. Because it isn't just about the top line, right? The bottom line, then eventually, because if you try to be all things to all people, you won't be able to sustain it. You can't operate it because you don't have enough wherewithal to do it. But if you can really focus, then I think that's a good way to get alignment in the incentives, not just incentives.
There's another way in which we can see this taking place in the industry today. So 20 years ago, health systems would buy physician practices. And the reason for that was that they wanted to own physician practices as feeders into their system, right? So they would own the physician practices that would cause them to be feeding the patients into their specialists and into their hospitals. Today, health systems aren't buying primary care offices anymore. It's the insurance plans who are buying the physician practices. And now their role is not anymore to be a feeder, but more to be a keep out role, right? I wouldn't say blocker. Physicians still refer patients to specialists in hospitals, but less so and more judicially so. And I think that has become the new role. So it's very interesting. You see that just in the market, you see the effect of that change, that now primary care physicians typically are bought by organizations that have the financial incentive to keep people away, to avoid as much as possible acute care.
All right, Harman, just to kind of leverage off of where we're going, how do community-based organizations play a role in directly addressing the unique needs of communities in enhancing health outcomes?
Yes, super important. And that here, another entire different angle on this value-based care story, it's the shift toward health equity and considering the patient's social determinants of health, and then to incorporate those into the patient's health plan. For example, I have a patient with intermittent periods of homelessness. I would like to refer that patient to a housing organization. So today, the digital health space is working on tools and systems to facilitate that referral, to identify the community-based organizations that can help to address the patient's situation, to refer the patient, and then to close the loop on that referral when the patient actually connects with this organization. So refer the patient to a community-based organization, have the patient receive services, close the loop back to the practice to say, yes, this patient is now indeed receiving housing services, food, transportation, benefits coordination. There are many services that the patients can benefit from in addition to their traditional healthcare services. So that too is a project. It's not a reality. So that project requires a lot of design and redesign for partners that are actually not traditionally in the healthcare space. So a food pantry doesn't have an electronic health record. They don't speak HL7 or FHIR, right? The methods we typically use between health information systems. They don't have a business associates agreement, which is typically the contract in which we together deal with patient information. And most importantly, also, they might not get paid by the health plan. So that is an entirely different world. And now we're seeing these worlds connecting through digital tools.
All right, let's talk about clinical change management. It's a hot topic we've debated over the last few weeks offline. With the shift toward value-based care, can you explain some of the key changes required within clinics to integrate and use these digital tools effectively, which could cause a change in workflow, could also impact a huge change in culture?
Yeah. I think if you were a patient and if you would walk into a practice that is typically focused around value-based care, you would see the difference the moment you walk in the door. In a traditional practice, there's the office staff, there's the medical assistant and the nurse, and there's the doctor. And that's typically the care team that you deal with in a traditional practice. In a value-based care practice, in a practice that is much more focused on managing a population, that same team exists, but in addition, you'd have behavioral health, social worker, community worker, care assist, care manager, care coordinator. There's many other roles. And the team works together on each of these individual cases and coordinates with each other to say, what is the best way that we can take care of this patient for their health, but also to make sure they don't need to go to the hospital. We manage their care sufficiently. So team is number one. Very different set of roles in a value-based care practice team. With team comes workflow. Once I have a different team, I need a different workflow, right? I need to coordinate my care differently and I need to make sure that everybody on the team knows where we are with this patient and know who's next in line to take care of that patient. So workflow becomes different. With workflow becomes technology. So that's why I'm shifting from a traditional electronic health record into a much more a population health management system. See the difference? I'm going to say it again. You change the team, then you change the workflow, then you change the technology. It is just a cascading way of making sure that everything is accommodated to this new way of working. And then one more we'll talk about more is shifting the care from traditionally the point of care, which is meaning I see the patient in my practice, to the point of need, which would be in the patient's home. And that will introduce another set of challenges, which we'll talk about in a second. Point of care to the point of need. It's super interesting how that may work.
So I guess, Harm, in your community in Philadelphia, what does that look like? What is the population health management system? What is that? A suite of tools? Is that a particular organization? How does that work, I guess, in Philadelphia?
Not just in Philadelphia, but I think generally in the country. I think there's two schools of thought on this, and it depends a bit on the type of organization. School of thought number one is that I use a set of tools, population health management tools, that come with my EHR vendor. So my electronic health record company, that could be Epic or Oracle Health Cerner or Meditech or eClinicalWorks or NextGen. They typically today have a set of population health tools embedded in them, and I might just use those tools to help me manage the population. That's school of thought number one. School of thought number two is that I add a specific set of population health software systems onto my electronic health record. So I create a separate suite. The benefit of that usually is that these individually smaller companies tend to be more up-to-date and more sophisticated sooner than the large EHR companies. They develop this function faster. So I get there faster. But the challenge is that I might now have two separate systems going on. So it's pros and cons on both sides. I think third-party add-ons for population health deliver more sophisticated functions, usually faster, and are able to keep up faster with the change of value-based care. But I now need to manage the fact that my users might need to be in two systems and be very smart about how I integrate those systems to make sure I do not disrupt the workflow for the care team. Those are the two schools of thoughts. I see both of them happening side by side. I don't have necessarily a preference. I just see both pros and cons on both sides.
Got it. Thank you.
All right, Harm, let's talk about ROI and success metrics. In particular, within hospital-to-home programs, how should leaders measure the success and ROI of digital engagement initiatives?
Yeah. ROI is hard. ROI is so hard to measure in health IT. It's funny, every company, every health IT firm says our system will prove to improve your ROI, but it's very, very difficult to prove that. But there are some simple measures that I could use to identify and measure ROI. Ultimately, it's a blend of quality measures and utilization measures. I need to make sure that the quality of care is high and my utilization, hopefully, if it all goes well, my utilization of acute care goes down. So those are the two main measures. Many ACOs participate in shared savings programs, so they submit their quality metrics as to demonstrate that they qualify for shared savings using high quality scores. At the same time, they need to achieve those shared savings by reducing acute care utilization and reducing overall cost of care for the patient. I think the simplest ways to measure ROI is purely looking at acute care utilization. That's the biggest driver. So I would say for my population, ED visits, number of emergency room visits per 1,000. It's a simple metric, it's easy to measure, it's easy to track, and it's a huge indicator of acute care utilization. ED visits per 1,000 would be my metric number one. And the second one right next to it is hospitalizations per 1,000, either admissions per 1,000 or hospital days per 1,000. But those are the two main indicators of acute care. I think in the current stage, those would be the best measures of ROI and effectiveness for a practice or a health system or an ACO. Underneath that, there are many more sophisticated measures, but let's start with those two.
Yeah, I think, well, that's an important point in terms of the language. So, the ROI versus the effectiveness, right? That efficacy, that's really what you're trying to measure, because you're spending money either way, but which one's working, which one's not. And I guess where does that data come from, Harm? Is that just a composite of different health systems coming together? I guess how do you collect that, in a population health context?
Great question. I feel that my answer to every question is that there's two of them, right? There's two ways. First of all, the payer, the health plan, will usually share those measures with their providers. So you get a report every 3 months or 6 months from your healthcare provider that tells you, here's how you're doing based on cost of care, quality measures, number of ED visits, number of hospitalizations. Most payers, and including Medicare, share that data with their providers. But it often takes very long to get those numbers. It's a long delay and it takes long. So the other way is the Health Information Exchange. As you know, I'm the Chief Medical Information Officer at HSX. We track real-time emergency room admissions, hospital admissions, and we're able to share that real-time with the providers who participate. So that is a much faster way for practices to know, how am I doing as a practice in terms of acute care utilization, and which patients are driving this? Where is my subset of patients who are the key drivers to acute care utilization? I think that's the key point. Two ways, the payer or the Health Information Exchange. Every state today has one or more Health Information Exchange organizations. They all provide this function as a help track the emergency room visits and hospitalizations for their patients. So I think that is probably the best source of acute care utilization, real time, and in a way that you can very quickly react as a practice to that acute care utilization.
Perfect. Thank you.
Harm, as healthcare increasingly shifts from hospitals to homes, can you share an example where digital engagement was crucial for a hospital-to-home program?
Yeah, I like to talk about this because that is fun. That is really where design comes back into the discussion. We said earlier, form follows finance. But for this particular topic, I think we're back to form follows function. Because if care moves from the practice to the point of need, the point of care to the point of need, which in this case, the patient's home, that means there will be a combination of telehealth, home care, home visits, whatever the program supports. And that requires design for this entirely new care environment. So we should talk about a bit more about that.
Yeah, well, that's definitely one where I think the incentives align, right? The patient wants to stay home too.
Yes.
So
great point, Keith. Absolutely. Yeah. I think it's better for all.
Everybody.
And the patient also stay home. It's better to keep a patient in their home using assistant tools, whatever level of care that patients would afford the patient to stay home. So that we clearly see that trend happening also. In order, yes, it benefits the patient, but also in order to reduce the need for acute care utilization. It's very much part of that same story. It's
Part
the
of
same
that's right.
driver is at work here. Mhm.
I wonder if you can delve a little further into how the design of the home workspace affects these transitions and what specific elements are critical for success.
Yes. To make that work, right, we may need to design the workspace, which is now in the patient's home, to be safe and to be effective and to be easy both for the patient and for the caregivers, and also easy, effective for the home care team. So that means simple things such as lighting and workspace, space for me to work, desk space, workspace, communication space. It might be a very cramped or messy situation, but as a caregiver, I need good lighting, I need good workspace. Simple. I also need hard things. I need remote patient monitoring devices. Those are complicated, and I need those too. I may need telehealth devices in which I can communicate with the patient while I'm not in the building. So that requires a redesign of the patient's home environment in a way that I can very effectively and safely deliver care there. Clean, safe, comfortable, predictable. I want clinicians to know where things are, where to find them, how to use them, just like in the hospital, but now in the patient's home. So we need to standardize and really design that workspace at the patient's home. And I think that's where kits come into play, modular, connected, and designed to fit the patient's home at the point of need. And that then also needs to include connectivity and interoperability to the electronic health record and possibly health information exchange. It's a complex task, but I think that's where the design for a specific home-based patient care kit comes into play.
And that's, adding all those elements sounds like you're really upping the level of complexity because you get into all the different overcoming those challenges as if the existing care settings aren't hard enough.
Yes.
But I think it's exactly right. Aspirationally, that almost has to be our goal, in this work. And so I love the vision. I think it's, it's important to continue to keep an eye on that mission.
Harm, taking on that theme, how do you envision scaling these designs to accommodate various home environments, considering that we don't own these spaces like we would a hospital or an ambulatory setting?
Yeah. Well, I want to draw another parallel here to answer that question. And I used to work in a hospital as CMIO, and there you also deal with a care team and a patient, where it's designed for teamwork, patient safety, efficiency. But of course, inside a hospital, organization, I own the space. I can design whatever I want because it's my building, it's my space. For example, in an ICU setting, the clinical team doing rounds usually works around, and the team typically tends to be large, right? A good number of physicians, residents, nurses, pharmacists rounding together. To make that work, we see carts with large screens, sometimes 2 screens, easy for the team to get around, to deliberate, to place orders, to review the data, to do some documentation. And that has to be mobile, so that typically is on a cart that moves around. The cart is high, the team stands up, and they all look at screens and talk together. I think it's the perfect situation for basically a team huddle around the patient, but with the screens in place that allow me to act and react, and that is mobile. That is design in an ICU. Now take that into the patient's home. Of course, that's very, very different, but similar. The same design. Here's different. We don't own the home. We can't even predict what the design constraints are inside a patient's home. So that's why we have the concept here in kits, in modular components. And I think that answers your scalability. To scale that, we should not think into large carts or large screens. We have to scale that down into kits, modular components, still be on a cart, still be mobile. I think mobility is important. Every space requires things to move, so mobile is important, but configurable to the specific setting. It needs to be well designed, it needs to be functional, it needs to be effective, an effective platform. So that is the type of design that we need to make clinical care work well in the care setting where we do not have a lot of control over the physical space. And I do like that approach around kits to create this flexible but still predictable workspace design.
Yeah, so Harm, I think we've actually had some of those similar conversations and talked about how, if we're going to do something by design, taking some of the themes we're talking about at Beyond the Blueprint and putting them into practice. So a couple of the key themes that we kick around as part of this environment is, say, operating at the intersection of the CMIO and the supply chain leader, where they have to come together and figure out practical ways to deliver this type of care. But then we're always talking about, well, then who would sponsor that? So let's just say hypothetically, we're looking for a sponsor. Is that the payer? Is that the provider? Is that somebody else? Or is all, what do you think that looks like if you got somebody to actually try to sponsor that kind of effort to design for that kind of outcome?
I think the sponsor for that kind of outcome would be the provider.
Provider, okay.
Because the provider took on a certain amount of financial risk, so they became Pay-Vider. And so the real answer is the Pay-Vider, which means a provider who is carrying responsibility for a group of patients and therefore has the incentive to also maintain the patients at home. I think that would be the typical role of the and they are also typically responsible for the team, including the home care team. So in most cases, I think I would say it's the provider organization, Pay-Vider organization, who would be the sponsor of these types of initiatives, because they're, at the end of the day, they're the beneficiary, right? You need to always, here we go, forward follows finance. Who benefits from maintaining a patient at home, and therefore who is going to make the investment to make that work well? In the new value-based care setting, that's the Pay-Vider, typically centered around provider organization.
Right, and so I think I like that.
Harm, thanks for all your insights. It's great having you as a guest. Today, you described how innovative strategies are enhancing engagement in population health. You discussed design strategies that align technology and human factors. You shared some great case studies with us on how digital initiatives are impacting outcomes. You identified obstacles, and you also explored how change management can help integrate this within provider practice and culture. Our discussion aligns closely with Spyglass's recent research in digital engagement we published last year. For those of you not aware, Spyglass is a product and go-to-market advisory firm focused on disruptive technologies and growth opportunities within the healthcare and life sciences industries. We have more than 250 customers who are leading technology companies, management consulting firms, healthcare providers, and investment organizations. We published more than 30 market research reports on a variety of informatics-related topics. To explore Spyglass's extensive library of paid research and gain deeper insight into how technology is reshaping healthcare, I encourage you to go to my website at www.spyglass-consulting.com. Well, Harm, I'd like to thank you for sharing your insights and perspectives. I'd also like to thank our sponsors, Storage Systems and Simplify Medical, who made this conversation possible. Harm, would you like to provide us with any closing remarks?
Yeah, I think we should just briefly recap the topics we traced today, and let's start at the beginning. Form follows finance. I think that's where we started. Change in payment systems, changing these incentives, changing who bears the risk. That has an impact on care delivery, and we see these changes happening right now. They're shifting us away from acute care and specialty care toward much more comprehensive primary care, and that movement in care setting is also shifting us away from the point of care to the point of need, the patient's home. I think that's just important to keep an eye on, and it's good. It's good for the patient. It's good for the health system, and that's, I think, the impact of value-based care on how we deliver care today in the United States. Together with that, and as a second point, there's a strong movement to include non-traditional services, community-based services, food, housing support, mental health services, benefit services, etc. All examples of community-based organizations driven by the focus on social determinants of health. And I will say that again, it's driven by value-based care, the shift in payment incentives, and the realization, and very important, the realization that a huge part of a patient's healthcare needs are not clinical, but are societal and social. And I think the last closing remark I would have is about the design idea. Like when the point of care changes, we need to design for that transition, create a safe, efficient, and effective workspace for caregivers, for the patient, for the family. And while in a traditional hospital setting, I have full control over the workspace, here we don't. So we need a flexible, light, modular design using kits and carts so workers know where things are and can be organized, effective, and safe. I think those are the three main takeaways from today's conversation.
Awesome. Keith, would you like to share any final thoughts on today's webinar?
Yeah, no, I really appreciate the time, Harm. I appreciate the insights. I appreciate the work you do. This is very inspiring to see this kind of work going on. It's the strategic approach, using design, using the tools, the technologies, the data, to really kind of move things forward in this with a sense of community. Because to me, that's really where, wherever you live, you want to live in a market where the health system is performing at its highest level, most efficient, giving you the best outcome. So I really appreciate the nature of this work, trying to tie together all these pieces that I don't think they were designed to go together, but I think there's this opportunity to go through a redesign and kind of get to where you're going. I really appreciate that.
I think you're right about it, Keith. Yes, it's not just design, it's redesign. And it's ongoing redesign. This will not end. I think this is an ongoing process. So I really like that you said that. It's not a one-time design and now you're done. It's ongoing redesign and optimization. I agree with you.
Yeah, adaptive is the way I think about it.
Yeah. Absolutely.
Very good.
Thanks, Keith. Thanks, Harm. Well, at Beyond the Blueprint, we look forward to continuing our conversation with you in the future episodes of this series. Harm, I hope we can invite you back for a future episode for another informative discussion.
Great. Thank you.
Thank you.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.